In this lecture, we will be discussing inflammation and a variety of drugs that are used to treat inflammatory disorders. And the reason behind that is that many of the diseases that involve the musculoskeletal system are inflammatory disorders such as rheumatoid arthritis, osteoarthritis, psoriatic arthritis, etc. So let's go back to your immunology. You have all learned that inflammation is an important physiological response that acts as a protective mechanism against tissue injury, which can be caused by a variety of noxious stimuli, such as physical injury, chemicals, irritants, or even invasion by foreign microbiologic organisms. Inflammation is the body's effort to inactivate or to destroy these invading microorganisms or to remove those irritants or obnoxious chemicals, and then to facilitate or to set stage for tissue repair. This means that inflammation plays an essential role in maintaining homeostasis. Note here that inflammation is usually a reversible response in that after the removal of the abnormal stimulus or the pathogenic microorganism, and inflammation subsides following allowing the damaged tissue to start the healing process. So inflammation is a useful, beneficial physiological response. And as you also remember that inflammation is mediated by members of the immune system, in particular white blood cells, and a variety of cytokines and chemokines that are secreted by these white blood cells when they are activated in response to either entry of foreign microbiologic organisms or a foreign body or an irritant chemical. However, inflammation can actually go wrong and it can become a pathologic mechanism, and that's the case actually in diseases such as rheumatoid arthritis. In those cases, inappropriate activation of the immune system can result in an abnormal inflammation, leading to immune-mediated diseases. Normally, the immune system can differentiate between self and non-self antigens. However, in these autoimmune diseases or these inflammatory diseases such as rheumatoid arthritis, white blood cells view the synovium or the synovial tissue as a non-self or as a foreign antigen. And in consequence, the immune systems initiate an inflammatory attack, trying to destroy and get rid of the synovial cells. So in that process, white blood cells also become activated, and that leads to the stimulation of T lymphocytes. So T lymphocytes mediate largely the pathogenesis of rheumatoid arthritis. T lymphocytes can also recruit and activate monocytes and macrophages, and these cells, as you all know, are responsible for the secretion of degradative enzymes and phagocytosis. And after T cells, macrophages, monocytes are activated, they will start attacking synovial cells and the destruction process begin. So all of these cells can also secrete a variety of pro-inflammatory cytokines, including tumor necrosis factor alpha, interleukin-1, interleukin-6, and interleukin-8. And these factors further promote the activation of further immune cells to continue the inflammatory process until the removal of the foreign antigen. Of course, in the case of rheumatoid arthritis, the attempt is to kill and eliminate the synovial cells, and that leads to a prolonged, chronic, destructive inflammatory process directed against the host tissue cells. So as I mentioned, T cells and other cellular components of the immune system play an important role in the pathogenesis of rheumatoid arthritis. but also those inflammatory cytokines contribute to the long-term effects of the inflammatory process involved with rheumatoid arthritis. And the release of these cytokines from T cells, macrophages, and monocytes results in a variety of processes that actually account or contribute to the pathogenesis of rheumatoid arthritis. One of the mechanisms that happen due to the release of pro-inflammatory cytokines is that these factors can promote or increase vascular permeability, resulting in increased infiltration of white blood cells into the site of inflammation. And that is usually due to the release of vasoactive substances such as histamines, kinins, and vasodilatory prostaglandins. In addition, the release of pro-inflammatory cytokines stimulate hepatocytes to produce a phase-reacting protein called C-reactive protein. Okay, and C-reactive protein is usually released into the plasma, and it's one of the markers that can be tested in labs in patients with chronic inflammatory disease to monitor the progress of their inflammatory condition. Moreover, pro-inflammatory cytokines can also stimulate the release of degradative proteolytic enzymes by a variety of cells, including chondrocytes and the attacking macrophages and monocytes. And those degradative enzymes, which usually are used during inflammation to kill, for example, bacteria, these enzymes are released in the synovial space, and they can result in the degradation of cartilage. And that is one of the features of rheumatoid arthritis. Pro-inflammatory cytokines can also result in osteoclast differentiation or an increase in the activity of osteoclasts. And as you all know, osteoclasts mediate bone remodeling, and when they are overactivated, they can result in the formation of focal bone erosions and even osteoporosis. Note here that it's very important to know that the inflammatory process involved with rheumatoid arthritis is not just limited to the synovial space or to joints. In fact, rheumatoid arthritis is a systemic inflammatory disorder because that abnormal activation of the immune system results also in systemic manifestations in other tissues such as the heart, lung, and liver. And that is why patients with rheumatoid arthritis usually have extra-articular symptoms, meaning symptoms that involve other organ systems besides the joints. So all these defensive reactions, the activation of the immune cells and the release of the pro-inflammatory cytokines can result in a progressive, ongoing tissue injury, resulting eventually in joint damage and erosions, which can lead to functional disability, significant pain, and reduction in the quality of life. And again, just to remind you that rheumatoid arthritis is associated with symptoms that involve other organ systems. And that is actually very important clinically because it will help you to differentiate between rheumatoid arthritis and some other inflammatory disorders that also affect the musculoskeletal system, or even the chronic degenerative processes that can affect joints that probably will have a clinical presentation similar to rheumatoid arthritis, such as osteoarthritis. So in osteoarthritis, it's very rarely that you would see a patient with an extra-articular manifestation. So the pharmacotherapy in the management of rheumatoid arthritis includes, as it would make sense, a variety of anti-inflammatory or immunosuppressive agents, because if the immune system is abnormally activated, the solution to that problem is to use anti-inflammatory immunosuppressive therapy to reduce the ongoing damage resulting from the abnormal activation of the immune system. So the goals of the pharmacological therapy of rheumatoid arthritis is to reduce inflammation and pain. This is important. This is the first thing you want to do. But more importantly is that this therapy is directed to slow down the disease progression and the ongoing destruction of the synovial space. For that, we have a variety of drugs, and these drugs are, of course, not specific to rheumatoid arthritis. They can be used in a variety of inflammatory disorders. The first category is the non-steroidal anti-inflammatory drugs with the prototype drug Aspirin, and we will discuss some of these examples as we go through this lecture. And then we have drugs that are more specific to rheumatoid arthritis. These are used to modify or reduce the progression of the disease. And those drugs are usually called the disease-modifying anti-rheumatic drugs, or DMARDs. So let's start first by discussing non-steroidal anti-inflammatory drugs. In order to understand how these drugs work, we have to revisit the pharmacology and the biochemistry of prostaglandins, because non-steroidal anti-inflammatory drugs work by inhibiting the synthesis of prostaglandins. As you remember, prostaglandins are unsaturated fatty acid derivatives that are composed of 20 carbon atoms and a cyclic structure. These compounds play a very important role in regulating several physiological mechanisms. They are produced in very little quantities by almost all tissues, and they act locally on the tissues at which they are synthesized and secreted. Prostaglandins are also rapidly metabolized into inactive products, and that's why their action is limited to the tissue that secretes them, and the concentrations of prostaglandins in the blood are very little. Thromboxanes and leukotrienes are also related lipid compounds that are synthesized from the same precursors as prostaglandins, and they also have a distinct set of functions. So how are prostaglandins synthesized? Prostaglandins are synthesized from arachidonic acid. Arachidonic acid is the primary precursor of prostaglandins and the other related compounds such as thromboxanes or leukotrienes. It is present as a component of phospholipid-based membranes, so it's found in cellular membranes of the cell, including the plasma membrane, and it's then released from these membranes by the action of the enzyme phospholipase A2. This enzyme is regulated and expressed in response to a variety of stimuli and hormones. Free arachidonic acid, after being released from the membranes, can be converted into a variety of substances through two major pathways. The cyclooxygenase pathway, which leads to the synthesis of prostaglandins, and then the lipoxygenase pathway, which leads to the synthesis of leukotrienes. So all these compounds, including prostaglandins, thromboxanes, and prostacyclins, are synthesized via the cyclooxygenase pathway. Now there is two related isoforms or variants of the cyclooxygenase enzymes. These are cyclooxygenase 1 and cyclooxygenase 2. Cyclooxygenase 1 is responsible for the physiologic production of prostaglandins, which means that all the prostaglandins that are released and synthesized in the tissues are synthesized through the cyclooxygenase 1 pathway. That what happens during normal physiological functions during homeostasis. However, with the cyclooxygenase 2 enzyme, which is also expressed constitutively in certain tissues such as brain, kidneys, and lungs, is on the other hand causes the elevated production of prostaglandins that occur at the sites of chronic disease and inflammation. This means that cyclooxygenase 2 is an inducible enzyme and usually induced by factors such as oxidative stress, injury, ischemia, seizures, etc. So cyclooxygenase 2 seems to have a more involvement in the context of disease processes. Again, cyclooxygenase 1 mediates the synthesis of prostaglandins that are involved in normal body functions such as gastric cytoprotection, vascular homeostasis, platelet aggregation, and reproductive and kidney function. Now, non-steroidal anti-inflammatory drugs in general are non-selective, meaning that they can inhibit both the cyclooxygenase 1 isoform and the cyclooxygenase 2 isoform. There's a new class of drugs called selective COX-2 inhibitors, which we will discuss in this lecture, that have the ability to selectively interfere with COX-2 function. And the reason that we can selectively interfere with COX-2 function is that these two isoforms of cyclooxygenase are not exactly the same. So if you see here, cyclooxygenase 2 active site has a larger substrate binding site in comparison to COX-1, and that is why we can target COX-2 with selective drugs that have minimal activity on COX-1. Remember here that the selectivity of the majority of non-steroidal anti-inflammatory drugs to either COX-1 and COX-2 is very important in determining how these drugs should be used, since COX-1 and COX-2 mediate different physiological effects. So, alternative to the cyclooxygenase pathway, the lipoxygenase pathway is responsible for the production of leukotrienes, and of course we have a group of drugs such as zeviroclass, montelukast. These drugs inhibit lipoxygenase pathway, inhibit the production of leukotrienes, and they have clinical uses, for example, the treatment of asthma, which you have covered in the respiratory module. So again, let's go back to prostaglandins and their physiological function. As we mentioned, prostaglandins have a major role in modulating pain, inflammation, and fever. They also control many physiological functions such as acid secretion, mucus production in the gastrointestinal tract. They can also regulate uterine contractions. During labor, they also regulate renal blood flow. So prostaglandins are also among the chemical substances that are released during allergic reactions and during inflammatory processes. And this is what's important for the sake of this lecture, is that prostaglandins are inflammatory mediators as well, and they are secreted in the context of inflammatory diseases. And for that, they become targets for drugs such as non-steroidal anti-inflammatory drugs, but also prostaglandins themselves, since they have the ability to exert all of these functions, they can also be used as drugs or as therapeutic agents. And despite that these prostaglandins have very similar structures, they can exert very different functions as well. For example, prostacyclin or prostaglandin I2, if you remember from the hematopoietic system, this prostaglandin mediates vasodilation. However, the other prostaglandins, such as prostaglandin F2 alpha, mediates vasoconstriction. Thromboxane as well mediates vasoconstriction and platelet aggregation. So they have opposing functions. So different prostaglandins released at different tissues work in balance to maintain the physiological homeostasis. So based on the unique function of each different prostaglandin, we have a variety of drug analogs that can be used to treat certain diseases utilizing that function of prostaglandins. For example, a drug called alprostadil, which is basically prostaglandin E2, is widely used for the treatment of erectile dysfunction and also in the treatment of congenital heart disease, and that is something that you have covered in the cardiovascular system. Misoprostol, for example, is another prostaglandin E1 analog that is used for the protection of gastric mucosa in patients who take non-steroidal anti-inflammatory drugs. Remember that prostaglandin E2 is a very important substance that maintains mucus secretion in the gastric mucosa, and thus it's protective for the gastric mucosa against acid. And that is why we can use it in combination with non-steroidal anti-inflammatory drugs that inhibit the synthesis of prostaglandin E1 and can result in gastric damaging effects, as we will see in this lecture. Of course, the uses of misoprostol will be covered in more depth in the gastrointestinal system. Prostaglandin F2 alpha analogs are also used for the treatment of glaucoma, and you will take that when you take ophthalmology, and you probably have also discussed the use of prostacyclin analogs for the treatment of pulmonary hypertension in the cardiovascular system. So can any of these prostaglandin analogs be used for the treatment of inflammatory disorders, let's say rheumatoid arthritis, for the sake of this lecture? The answer is not directly. They can actually be part of the treatment regimen for rheumatoid arthritis, not to treat the inflammatory response, because drugs such as misoprostol is expected to have a pro-inflammatory response. However, misoprostol can be combined with non-steroidal anti-inflammatory drugs, as I said, because they have gastric cytoprotective activities. Chronic use of non-steroidal anti-inflammatory drugs is associated with increased risk of gastric injury, and that is because they inhibit the synthesis of protective prostaglandins in the gastric mucosa. So sometimes we need to combine them with a prostaglandin E2, E1 analog such as misoprostol to protect the gastric mucosa from the chronic use of non-steroidal anti-inflammatory drugs. So their use in this context is an adjunct to the anti-inflammatory drugs that are needed for the treatment of rheumatoid arthritis or osteoarthritis. So non-steroidal anti-inflammatory drugs are a group of chemically different agents that have different antipyretic, analgesic, and anti-inflammatory functions. This class includes a variety of drugs, including salicylate derivatives, such as aspirin, which is the classical prototypical drug of this family. However, there are many other derivatives of salicylates that are also categorized as non-steroidal anti-inflammatory drugs, in addition to other drugs that are commonly used in the clinic, including indomethacin, ibuprofen, naproxen, ketoprofen, mefenamic acid, and so on and so forth. The main action of non-steroidal anti-inflammatory drugs is by primarily inhibiting cyclooxygenase enzymes that catalyze the first step in prostaglandin synthesis. This leads to decreased prostaglandin synthesis with both beneficial and unwanted effects. Remember that while prostaglandins are important mediators of inflammation, and that's why we use NSAIDs to inhibit their synthesis in the context of inflammatory diseases, but they also exert lots of useful physiological functions. So what happens when you inhibit the function of COX-1 enzyme? that will result in a reduced synthesis of all the prostaglandins produced by COX-1, and that results in unwanted effects that affect the gastrointestinal system. As you know, chronic use of non-steroidal anti-inflammatory drugs can result in gastric mucosal injury. These drugs can also result in bleeding because prostaglandins are also involved in the homeostasis of platelet aggregation. That's why, for example, aspirin can increase the risk of bleeding, as well as because they regulate the renal blood flow. Inhibition of prostaglandin synthesis by inhibiting COX-1 function can also result in renal toxicity. Selective inhibition of COX-2, on the other hand, results in totally different effects. It can be useful because inhibition of COX-2 can have an analgesic effect, an antipyretic effect, and anti-inflammatory effect. However, you don't get any of those effects involving the gastrointestinal system. So, in patients who are at increased risk of developing gastric ulcers or have a gastric disease, it is advised that we switch to the selective COX-2 inhibitors because inhibition of COX-2 does not exert the gastrointestinal side effects of COX-1 inhibitors, while maintaining the anti-inflammatory effects that you want when you are treating a chronic inflammatory disorder. However, selective inhibition of COX-2 has some side effects, and that includes renal toxicity, because these drugs also reduce renal blood flow and increase renal pressure, and they can be associated with an increased risk for developing thrombotic event, since they also lower the levels of prostacyclin. So these unwanted side effects should also be considered when a patient is going to be started on a COX-2 inhibitor. Let's talk a little bit about the prototypical drug of this group, which is aspirin, and many of these information that we will discuss here will be applied as well to the other non-steroidal anti-inflammatory drugs. Aspirin can be thought of as the traditional non-steroidal anti-inflammatory drug, but it only exhibits anti-inflammatory activity only at very high concentrations, at least at concentrations much higher than those that we use when we use aspirin as an antiplatelet. Of course, aspirin is more widely used at lower doses for the prevention of cardiovascular events such as stroke and myocardial infarction, but it can also be used as an anti-inflammatory drug um, if used at higher doses. One of the differences of aspirin from the other non-steroidal anti-inflammatory drugs is that aspirin irreversibly inhibits the cyclooxygenase pathway, and that lasts for example, like if in platelets, it lasts for the entire lifetime of the platelet. You need to synthesize new platelets to restore cyclooxygenase function because the inhibition of the enzyme is irreversible. The majority of the other non-steroidal anti-inflammatory drugs are reversible inhibitors of COX-2, and that's why their effects are usually reversed following discontinuation of the drug. Okay, so let's talk about each of the functions exerted by aspirin and the other non-steroidal anti-inflammatory drugs. The main function, which is the focus of this lecture, is the anti-inflammatory actions of these drugs. Cyclooxygenase inhibition diminishes the formation of prostaglandins, and thus it modulates aspects of inflammation in which prostaglandins act as mediators. Remember that prostaglandins are also inflammatory mediators. So if you inhibit their synthesis, you will, in general, block or lower inflammation. In rheumatoid arthritis, the non-steroidal anti-inflammatory drugs inhibit inflammation, but they don't interfere with the progression of the disease. And this is very important to know about non-steroidal anti-inflammatory drugs. They are very useful in mitigating inflammation, reducing pain, and reducing swelling that is usually noticed in the joints of patients with rheumatoid arthritis. However, they don't arrest the progression of the disease or induce remission. So they mainly exert their actions on the symptoms of the disease. This is very important. The second action of aspirin non-steroidal anti-inflammatory drugs is the antipyretic actions or anti-fever action. Again, inflammation that is usually associated with um, autoimmune diseases such as rheumatoid arthritis, or that is in response to microbial infections, for example, as you know, involves the secretion of pro-inflammatory cytokines, which induce the synthesis of certain prostaglandins, including prostaglandin E2. And prostaglandin E2 is very important in the regulation of body temperature, and it is, in fact, what mediates fever in patients who have an inflammatory condition. So non-steroidal anti-inflammatory drugs, including aspirin, they block the synthesis of prostaglandin E2, and they increase heat dissipation, which means increase the process of losing heat from the body through peripheral vasodilation and through sweating. The analgesic actions of aspirin and the other non-steroidal anti-inflammatory drugs are very important, especially for the treatment of rheumatoid arthritis, because patients with rheumatoid arthritis have a tremendous amount of pain that is not only involved to their joints. And here as well, prostaglandin E2 is thought to sensitize nerve endings to the actions of bradykinin, histamine, and other chemical mediators released locally through the inflammatory process. And these mediators are usually that send signals through the peripheral nerves to cause pain. That is why any inflammatory condition is usually accompanied by pain. Pain is a very important sign of inflammation. So by decreasing prostaglandin E2 synthesis using COX inhibitors or non-steroidal anti-inflammatory drugs, especially COX-2. Remember that COX-2 selective inhibitors are very potent analgesics, and we frequently use them for the treatment of pain. By inhibiting the cyclooxygenase pathway, we reduce the synthesis of prostaglandin E2, and that's how we reduce the sensitivity of peripheral nerves to painful stimuli. Remember also that COX-2 is expressed during the times of inflammation and injury. It's an inducible enzyme, not like COX-1, which is always active and present. COX-2 more becomes activated when we have an injury or inflammation. And that is why when we inhibit COX-2 function selectively, we probably get more potent analgesic effect. Now, do the different non-steroidal anti-inflammatory drugs differ in their analgesic effect in terms of efficacy? The answer is yes and no. No single NSAID has demonstrated superior efficacy over the other, and all these agents are generally considered to have equivalent efficacy in terms of their analgesic effect. But they definitely have different pharmacokinetics, and they can exert analgesic effects at different rates based on their pharmacokinetics. For example, the drug ketorolac can be used, for example, in cases of very severe pain because it has a short duration of action. But in general, all these non-steroidal anti-inflammatory drugs are useful, and they are used for the treatment or management of mild to moderate pain arising from musculoskeletal disorders. So based on those actions exerted by non-steroidal anti-inflammatory drugs and aspirin, we have a variety of diseases where these drugs can be used. One of the main therapeutic uses of non-steroidal anti-inflammatory diseases is actually as anti-inflammatories and analgesics, and that is not limited to diseases like rheumatoid arthritis and osteoarthritis, where these drugs play a very important role in the treatment. As you all know, non-steroidal anti-inflammatory drugs such as indomethacin and naproxen are first-line agents for the treatment of an acute attack of gout. Remember that salicylates are not used for the treatment of gout because they increase the plasma levels of uric acid. In addition to that, non-steroidal anti-inflammatory drugs are widely used for the treatment of headache, and you probably have all used drugs like ibuprofen, for example, or diclofenac sodium for the treatment of headache or muscular pain. These drugs can also be useful for the treatment of PMS or premenstrual syndrome, which is a condition that affects women's emotions, physical health that is usually associated with certain days of the menstrual cycles, often characterized with pain, painful menstruation, which we call dysmenorrhea. And lastly, these drugs are also very useful analgesics for the treatment of cancer pain, usually in combination with opioids, because opioids are more powerful analgesics, which we will discuss next semester. But the combination of NSAIDs with opioids can allow for using lower doses of opioids, which is always something that you want. Usually, non-steroidal anti-inflammatory drugs have similar anti-inflammatory analgesic and antipyretic actions, usually at the same therapeutic dose. But aspirin is different. The action of aspirin, or its ability to exert these effects, is dose dependent or concentration dependent. And I like this figure very much because it shows you how the dose of aspirin can determine which effect it will exert. So this graph here applies only for salicylates or aspirin. If you use aspirin at lower concentrations, such as from around 10 milligram per deciliter, aspirin will be able to exert analgesic, antipyretic, and antiplatelet effects. See, antiplatelet function of aspirin is achieved using low doses of aspirin. That's why we use baby aspirin for the protection against myocardial infarction, for example. However, if you want to achieve the anti-inflammatory effect of aspirin, the dose of aspirin must be increased. And in certain conditions, such as, for example, the treatment of rheumatic fever, which is another inflammatory disorder, we use aspirin, and physicians usually know that they have achieved the maximum dose or the maximum anti-inflammatory dose when aspirin starts causing tinnitus. More than 50 milligram per deciliter of aspirin in the blood will start having highly toxic, severe lethal effects. Okay, so this is basically the therapeutic range of aspirin. You will get antipyretic, analgesic, and antiplatelet effects at low doses, but you need to go up in the dose to achieve the anti-inflammatory effects that probably will be beneficial for a patient with rheumatoid arthritis. Aspirin, ibuprofen, and naproxen may be used to treat fever. They are frequently used for the treatment of fever. But there is an important note that aspirin should be avoided in patients who are younger than 20 years old that are suffering from viral infections, such as, for example, chickenpox or influenza. And the reason behind that is that aspirin can be associated with Reye syndrome, which is a syndrome that can cause fulminating hepatitis with cerebral edema and often leading to death. So we usually keep the use of aspirin as an antipyretic for patients who are older than 20 years old. Just a quick reminder that the way these drugs reduce fever or interfere with fever is through their action on reducing the synthesis of prostaglandin E2, which is one of the important prostaglandins released at the hypothalamic level, and it's very important for heat regulation, and it is the main mediator of fever in the setting of inflammation. Again, there are cardiovascular applications for aspirin. As you have discussed previously in the hematopoietic system, aspirin is a potent antiplatelet agent and can be used to reduce the risk of ischemic heart disease, cerebrovascular accidents, etc. And that is something that we have covered previously. Aspirin can also, or salicylic acid derived non-steroidal anti-inflammatory drugs can be used topically, and we have probably discussed some of these uses when we discussed the diseases of the skin, because salicylic acid is a potent exfoliative and can be used for the treatment of acne, corns, calyces, and warts, as it's available as in creams and other topical formulas. So let's talk a little bit about the pharmacokinetics of non-steroidal anti-inflammatory drugs, including aspirin. So after aspirin is administered orally, it is rapidly metabolized or deacylated by esterases in different parts of the body, thereby producing salicylate. So this is where the acetyl group of aspirin is removed, and that gives you salicylic acid. And then the unionized salicylates can be passively absorbed mostly from the upper small intestine. Salicylates then can circulate through the plasma and can cross both the blood-brain barrier, and they can also cross the placenta, and they are also highly absorbed through the intact skin. So salicylates are converted by the liver to water-soluble conjugates that are rapidly cleared by the kidney. So the elimination of aspirin metabolites is through the kidney, and that results in first-order elimination or first-order kinetic elimination of aspirin and its metabolites, giving a half-life or 3.5 hours. So when aspirin is used at low doses to exert antipyretic, analgesic, or antiplatelet functions, it has a relatively low half-life. However, when aspirin is used at anti-inflammatory doses, which can reach up to 4 grams per day, remember that to get the anti-inflammatory effects of aspirin, you need to use it at relatively high doses. That results in the oversaturation of the hepatic metabolic pathways of aspirins and salicylates, and that switches the elimination from first-order kinetics into zero-order kinetics, and that elevates the half-life of aspirin for up to 15 hours. Most non-steroidal anti-inflammatory drugs are well absorbed after all administration and circulate highly bound to plasma proteins. The majority are metabolized in the liver, such as aspirin, and most of them are metabolized into inactive metabolites. Remember that aspirin is metabolized into salicylate, which is an active drug metabolite. Of course, they vary in many of their pharmacokinetic profiles. They have different maximum doses that can be given each day, different dose ranges. For example, with ibuprofen, it can be given at 400 milligrams every 4 to 6 hours, while diclofenac is given at 50 milligrams every 8 hours. So these differences in how these drugs are given should be always taken into consideration, since these drugs are very frequently used in the clinic. So an important topic about aspirin and non-steroidal anti-inflammatory drugs are their side effects, because I will remind you again, these drugs interfere with the synthesis of prostaglandins, and then they interfere with the physiological effects of prostaglandins. One of the main problems that are associated with um, uh, chronic non-steroidal anti-inflammatory use is their gastrointestinal side effects. So the gastrointestinal side effects of NSAIDs are the most common adverse effects associated with their use, and they can range from mild dyspepsia to even severe bleeding of the gastrointestinal tract. Normally, the production of prostacyclin or prostaglandin I2 inhibits gastric acid secretion. And prostaglandin E2 and prostaglandin F2 alpha stimulate the synthesis of protective mucus in both the stomach and the small intestine. So prostaglandin exert protective effects of the gastric mucosa. Agents that inhibit COX-1 enzyme reduce beneficial levels of these prostaglandins, resulting in increased gastric acid secretion, diminished mucus production, and increased risk for gastric mucosal injury and gastrointestinal bleeding and ulceration. Agents with higher relative selectivity for COX-1 may have a higher risk for gastrointestinal events compared to those who have lower selectivity for COX-1. So this effect, the side effect of non-steroidal anti-inflammatory drugs is mainly mediated through COX-1. So can you avoid this adverse effects by using a COX-2 inhibitor? The answer is yes. And that's why patients who have a higher risk for developing gastrointestinal adverse effects or have a pre-existing condition in the gastrointestinal tract should be advised to use COX-2 rather than COX-1 inhibitors. If non-steroidal anti-inflammatory drugs are used in patients with high risk for gastrointestinal events, and there is no other way to go around this, these drugs must be combined with proton pump inhibitors or in combination with Misoprostol, as we have discussed earlier. Misoprostol is a prostaglandin E2 analog that has a gastric cytoprotective. The second very important side effect of non-steroidal anti-inflammatory drugs is bleeding, and that is mainly associated with the irreversible inhibition of COX-1 by aspirin. So aspirin is the example of non-steroidal anti-inflammatory drugs that are associated with bleeding. And the reason why is something that you've covered in the previous module, that inhibition of COX-1 reduces the formation or synthesis of thromboxanes that play an important role in the activation of platelets, and that chronic irreversible inhibition of COX-1 would increase the risk of bleeding. This is a common side effects of aspirin. So the third adverse effect associated with chronic non-steroidal anti-inflammatory drugs use is their effects on the kidney. Remember that prostaglandins uh, play an important physiological role in the regulation of kidney function. So non-steroidal anti-inflammatory drugs prevent the synthesis of prostaglandin E2 and prostacyclin that are responsible for maintaining renal blood flow. Decreased synthesis of prostaglandins result in retention of sodium and water and may cause edema in some patients. Patients with a history of heart failure or kidney disease are a particular high risk of developing complications following the use of non-steroidal anti-inflammatory drugs. Agents such as aspirin with very high risk or very high degree of COX-1 selectivity have shown a cardiovascular protective effect, right? We use aspirin to protect against ischemic heart disease. So they are cardioprotective, and that's a good thing. However, on the other hand, and this is very important, is that non-steroidal anti-inflammatory drugs that are more selective towards COX-2 have been shown to increase the risk for cardiovascular events. So COX-2 are very good for a patient with gastric disease or at risk of developing a gastric ulcer, but they are not useful for patients who have pre-existing or at a higher risk of developing cardiovascular events. This is a very important distinction between COX-1, COX-2 inhibitors because that will determine which drug you will be using to treat that patient. So let's take an example. Let's say that there is a patient with a cardiovascular disease who needs to use non-steroidal anti-inflammatory drugs and there is no alternative. We prefer drugs such as naproxen, which probably seems to be the least harmful since it has a higher COX-1 selectivity. So the selectivity of non-steroidal anti-inflammatory drugs is very important in understanding their therapeutic uses and their adverse effects. So as the drug becomes more and more non-selective, it means that it inhibits both COX-1 and COX-2, such as aspirin. These drugs have cardioprotective effects when used at low doses, but a huge risk for developing gastrointestinal bleeding and gastrointestinal side effects. Drugs that are less non-selective than aspirin, such as naproxen, ibuprofen, have a decreased risk for cardiovascular events, and that's why we said naproxen can be used in patients with cardiovascular risk, but they still have the risk to develop gastrointestinal side effects. That's mainly because they're not selective. They don't differentiate between COX-1 and COX-2, and they inhibit both enzymes. And as we said, the gastrointestinal side effects of NSAIDs are mediated by inhibiting COX-1. So as you move with the selectivity towards being more selective for COX-2 inhibitors, drugs such as celecoxib, which we will talk about in a minute, COX-2 selective inhibitors don't have the gastrointestinal side effects, so they can be safely used in patients with peptic ulcer disease. However, they increase the risk of thromboembolic events, and then they can complicate cardiovascular disease. So they can't be used with patients with or at risk of ischemic heart disease and other thromboembolic problems. Of course, there are other minor side effects of the use of aspirin and non-steroidal anti-inflammatory drugs. And of course, these are also a result of inhibition of prostaglandin synthesis. For example, remember that arachidonic acid can be metabolized into either prostaglandins through the cyclooxygenase pathway or into leukotrienes through the lipoxygenase pathway. So when you use aspirin or non-steroidal anti-inflammatory drugs, and block this pathway, there will be a more shift towards the leukotriene pathway, and that leukotrienes are known to cause bronchoconstriction. That's why if you use NSAIDs, there is an increased risk of causing bronchoconstriction, and that's why non-steroidal anti-inflammatory drugs should not be used in patients with asthma. And this is important because these drugs are, for example, used liberally in the emergency department to relieve pain. And anti-inflammatory drugs are potent analgesics. So you always need to ask patients if they have a history of asthma before giving them any of these non-steroidal anti-inflammatory drugs. They can also be associated with headache, tinnitus, and dizziness, and these are common adverse effects of aspirin. And of course, some patients have aspirin or non-steroidal anti-inflammatory drugs hypersensitivity. Do these drugs interact with other drugs? The answer is yes. And for example, salicylate and of course the other NSAIDs are heavily protein bound. Around 80 to 90% of salicylate binds to plasma proteins, especially albumin, and that is how it circulates in the plasma. And salicylate then can be displaced from protein binding sites, resulting in increased concentration of free salicylate. Alternatively, aspirin can displace other highly protein bound drugs such as warfarin. Okay, so either there will be a drug that has more affinity for albumin than salicylate, and that will displace salicylate into the blood, increasing its concentration, or aspirin and salicylate can displace warfarin that is bound to albumin, increasing its free plasma concentration. So when aspirin and warfarin are used in combination, you have to do those adjustments and monitor the patient, especially if it's combined with an anticoagulant such as warfarin. So of those other drug-drug interactions that are very important are combining aspirin with heparin or other oral anticoagulants because that increases the risk for hemorrhage, or if salicylate were combined with probenecid because that also result in decreased uric acid secretion in the urine and elevated plasma uric acid levels, and that can cause exacerbation of gout, for example. Are aspirin and salicylate associated with toxicity? Remember that we have discussed that there is a therapeutic window, a therapeutic range of the maximum dose that can use for aspirin as an anti-inflammatory drug. Following a certain limit, salicylate accumulates in the blood, it becomes toxic, and that is what we call salicylism. And that syndrome of increased salicylate in the blood can result in nausea, vomiting, hyperventilation, dizziness, and tinnitus. In cases of severe salicylic acid toxicity, patients can start developing hallucinations, convulsions, coma, and even respiratory failure and death. Remember that around 10 grams of aspirin can cause death in a healthy individual, especially in children. Can you use aspirin and non-steroidal anti-inflammatories drugs during pregnancy? Um, most of these agents are pregnancy risk category C, especially in the first 2 trimesters. And in that case, acetaminophen or paracetamol is preferred if an analgesic or antipyretic effects are needed during pregnancy. Now, in the 3rd trimester, non-steroidal anti-inflammatory drugs should be generally avoided because they can affect the development and closure of the ductus arteriosus. So they can lead to congenital heart disease. Okay, let's now talk about the selective COX-2 inhibitors in more detail. Okay. One of the major or most famous compounds that can selectively inhibit COX-2 is a drug called celecoxib. And celecoxib results in a selective reversible inhibition of COX-2. And I want to remind you one more time that the selectivity of non-steroidal anti-inflammatory drugs to COX-1 and COX-2 is very important. You need to know this because that would help you differentiate between their effects and their adverse effects. So the more the drugs become non-selective, means that they inhibit both COX-1 and COX-2. These drugs can cause severe gastrointestinal problems, but they are not associated with higher risk for developing cardiac disease. The more non-steroidal anti-inflammatory drugs become selective towards COX-2, such as celecoxib, these drugs have less harmful effects on the stomach, but they can be associated with increased cardiovascular events. So where can we use celecoxib? We can definitely use celecoxib for the treatment of rheumatoid arthritis and other inflammatory disorders because it has a potent anti-inflammatory effect. And it's also a very potent analgesic. And we discussed how celecoxib exerts analgesic effects, and it has similar efficacy to the non-selective non-steroidal anti-inflammatory drugs. Celecoxib is pretty often given orally and has a half-life of 11 hours. Celecoxib can definitely cause some adverse effects. It can cause headache. It can cause dyspepsia, but it doesn't cause injury to the gastrointestinal tract, and it's not associated with increased risk of gastrointestinal bleeding. That is why it's preferred to be used in patients who have GI problems. As I mentioned, it is associated with an established risk for cardiovascular disease, and that is one of the adverse effects that you should be aware of before giving celecoxib to a patient. So to summarize, non-steroidal anti-inflammatory drugs is a wide group of drugs that has antipyretic, anti-inflammatory, and analgesic effects. Remember that these effects, in case of aspirin, vary depending on the concentration of aspirin. So aspirin exerts antipyretic analgesic effects at lower doses, but you need to go to very high doses of aspirin to achieve the anti-inflammatory effects you need for the treatment of rheumatoid arthritis. Note that some of these agents um, are very potent and should be used only after less toxic agents have proven ineffective. And that's like, for example, indomethacin. It's a potent drug, but we use it in severe inflammatory cases such as an acute attack of gout. Um, Also remember that the selectivity of these agents dictates their adverse effects. The more non-selective the agent is, the more it will be associated with gastrointestinal problems. The more it becomes COX-2 selective, the more that it will have less irritation on the gastrointestinal tract, but it will start showing an increased potential for myocardial infarction and stroke. So these differences and others in the pharmacokinetics of these drugs are very important to know how to use them in the clinic. So non-steroidal anti-inflammatory drugs are used mainly for their anti-inflammatory function. They're very potent in mitigating or reducing the symptoms of rheumatoid arthritis, including pain, swelling, and erythema of the joints. So they reduce the inflammation. They're very potent and we use them all the time, but they have no effect on the long-term progression of the disease. They don't reduce tissue destruction of the disease, and they don't affect the long-term outcomes of rheumatoid arthritis. And that is why there is another group of drugs that can be used to affect the progression of rheumatoid arthritis and the deterioration of the disease, and these are called the disease-modifying anti-rheumatic drugs, or DMARDs. So these disease-modifying agents have several advantages that cannot be achieved by the sole use of non-steroidal anti-inflammatory drugs. The disease-modifying agents can actually slow the progression of rheumatoid arthritis. They can induce remission, and remission is a period of absence of symptoms, so the patient can go into a period where they no longer experience the symptoms of rheumatoid arthritis. They can definitely reduce or prevent further tissue destruction. Remember that rheumatoid arthritis is associated with an intense destructive process that destroy the synovial spaces. So these drugs can reduce that. They are usually recommended to be used as soon as possible. In most cases, we prefer the use of a single drug for cases of mild to moderate rheumatoid arthritis because these agents are associated with adverse effects. So we prefer using one drug. However, combination of therapy might be needed in cases of advanced rheumatoid arthritis. Of those disease-modifying agents, we have the prototypical primary drug methotrexate, in addition to hydroxychloroquine, leflunomide, and sulfasalazine. So the first drug in this family is methotrexate, and you have been introduced to methotrexate before as an anti-cancer and an immunosuppressant agent. Methotrexate exerts its effect by inhibiting or interfering with folic acid metabolism. It's a folic acid antagonist that inhibits the enzyme dihydrofolate reductase and prevents the conversion of dihydrofolate into its active form, which is tetrahydrofolate. In addition, that being a potent anti-cancer mechanism that interferes with DNA synthesis in cancer cells, methotrexate can also exert the same mechanism in rapidly proliferating cells of the bone marrow, which are predominantly white blood cells. Remember that one of the side effects of methotrexate is that it can cause immunosuppression. And in the case of rheumatoid arthritis, this immune suppression and anti-inflammatory effect seem to be useful. That's why methotrexate is the mainstay treatment of rheumatoid arthritis, and it's the most frequently used disease-modifying drug. Most of the time, the response to methotrexate happens within 3 to 6 weeks following initiation of therapy, and we prefer to use monotherapy, single therapy of methotrexate used as a single agent, and only add other drugs to methotrexate in combination in case there was a poor response or tolerance to methotrexate. A very important note to remember here is that for the treatment of rheumatoid arthritis, we do not use methotrexate at its anti-cancer doses because to treat cancer, methotrexate is given at a relatively higher dose than the dose that we use to treat rheumatoid arthritis. So for rheumatoid arthritis, we give methotrexate once weekly, and that can also be associated with adverse effects such as gastrointestinal complications, cytopenias, and anemia, liver cirrhosis, and acute pneumonia-like symptoms. Remember, there is a way to reduce the adverse effects of methotrexate. You can look that up. The second drug in this category is hydroxychloroquine, and you have also been introduced to hydroxychloroquine as an anti-malarial agent, and you probably have heard all the news about its use for the treatment of COVID-19 this year. But hydroxychloroquine also has immunosuppressive effects that have been shown to be useful for the treatment of early mild rheumatoid arthritis. And patients who are on hydroxychloroquine treatment can usually develop a response and improvement in their clinical condition in about 6 weeks to 6 months. Hydroxychloroquine can definitely have some ophthalmologic complications. It can cause gastrointestinal upset and skin discoloration. Leflunomide is an immunomodulatory agent. It has a unique mechanism of action. So in order to understand how it works, we need to go back and look at glutamine metabolism, which is also very important. It's one of the very important pathways for the synthesis of nucleic acids. Note here in this pathway that the end product is UMP, which is very important for DNA and RNA synthesis. So one of these steps involves the conversion of glutamine into UMP. So in that pathway, glutamine is converted to hydroorotate, and hydroorotate or dihydroorotate is then converted by the enzyme dihydroorotate dehydrogenase into orotate. This step is the target, or it's inhibited by leflunomide. So inhibition of dihydroorotate dehydrogenase enzyme reduces the production of orotate and then also reduces the production of UMPs. And since this is essential for DNA and RNA synthesis, inhibition of this pathway will reduce DNA replication. And that will largely affect rapidly proliferating cells, such as cells of the immune system, such as lymphocytes. Remember that T cells and B cells play an essential role in the pathogenesis of rheumatoid arthritis. So as a result, lymphocytes undergo a growth arrest and their activity reduces. And leflunomide is used as an alternative or in combination with methotrexate for the treatment of rheumatoid arthritis. The last drug in this category is sulfasalazine, which we still don't know its immunosuppressive mechanism of action, but it's been used for the treatment of several autoimmune diseases, not just rheumatoid arthritis, and its response is usually observed in up to 3 months following the initiation of treatment. So in addition to the conventional disease-modifying anti-rheumatic drugs, we have now a new class of biologic DMARDs. These drugs are basically all monoclonal antibodies that are different from those that have been used for a long time for the treatment of rheumatoid arthritis. And these drugs have now also changed the way that we treat rheumatoid arthritis and have tremendous improvement in the overall outcome and prognosis of the disease, and they are now used frequently for the treatment of DMARDs. So in comparison with the conventional DMARDs, which are non-selective, and they usually exert their immunosuppressive effects by suppressing the immune system and abrogating the function of white blood cells, the biologic DMARDs usually target certain pathways involved in the pathogenesis of rheumatoid arthritis, so they are more selective. Remember when we discussed the pathogenesis of rheumatoid arthritis, we said that the release of pro-inflammatory cytokines plays an important role in mediating the disease. And of those pro-inflammatory cytokines, it appears that interleukin-1 and tumor necrosis factor alpha are the main drivers of the inflammatory process associated with rheumatoid arthritis. These two agents both stimulate synovial cells proliferation, resulting in cartilage degradation, bone resorption, and other destructive features of rheumatoid arthritis. So targeting them will definitely reduce the progression of the disease. And that is why drugs have been developed to target the processes involved in interleukin-1 and tumor necrosis factor alpha signaling. And we divide those drugs into either drugs that inhibit tumor necrosis factor alpha or drugs that don't inhibit tumor necrosis factor alpha and inhibit other factors in the inflammatory process. These agents, as I said, massively decrease the signs and symptoms of rheumatoid arthritis, they reduce the progression of the disease, and they lower the structural damage. These are very, very important effects of these drugs. They can either be used as monotherapy or in combination in cases of severe rheumatoid arthritis. But there are some disadvantages with using these drugs. They have to be used with a tremendous amount of caution because they are potent immunosuppressants. They can definitely increase the risk for infections. They can, for example, be associated with reactivation of tuberculosis in patients who have latent tuberculosis. They can also increase the risk for developing opportunistic fungal infections. They can lower the number of white blood cells in general. And in patients who are taking biological DMARDs, those patients should not be given live vaccinations because they can be associated with the activation of viral infections and should be used very, very carefully in patients with chronic heart disease, especially heart failure, because they can worsen heart failure. Some of these drugs have also been shown to increase the risk of developing cancer, especially lymphoma. So, despite that they are very effective in modulating the disease progression of rheumatoid arthritis, these drugs have many serious adverse effects. The first drug in this group is adalimumab. And adalimumab is a monoclonal antibody that directly targets tumor necrosis alpha. And adalimumab blocks the interaction between tumor necrosis alpha and its surface receptor on immune cells and synovial cells, and that's how it interferes with the ongoing inflammatory process associated with rheumatoid arthritis. It is used for moderate to severe disease, and either as a single drug or in combination with methotrexate. Of course, since adalimumab is a strong immunomodulating drug, it can be used with other autoimmune diseases such as psoriatic arthritis, ankylosing spondylitis. Both are diseases of the musculoskeletal system, as well as inflammatory bowel disease such as Crohn's disease. Adalimumab is given subcutaneously, and it's associated with adverse effects that include lowering the number of white blood cells, increasing the risk of opportunistic infections, and possibly a local reaction at the site of injection. Certolizumab is a unique tumor necrosis factor alpha blocker that contains a Fab fragment of a humanized antibody and is a potent neutralizer of tumor necrosis alpha. It is combined usually with polyethylene glycol and is administered every 2 weeks via subcutaneous injection. And it has a similar therapeutic profile and similar indications to adalimumab. The adverse effects of certolizumab are the same as the other biologic DMARDs. Etanercept, which you have probably been introduced to previously as a potent immunosuppressant agent, is a genetically engineered soluble recombinant fully human receptor fusion protein that binds to tumor necrosis alpha, and thereby it blocks its interaction with its receptors, and that's how it interferes with the inflammatory process associated with rheumatoid arthritis. This agent has been approved for the use in patients with moderate to severe rheumatoid arthritis, either alone or in combination with methotrexate. It has also been approved for the use of ankylosing spondylitis and psoriatic arthritis. The combination of etanercept and methotrexate is actually more effective than using methotrexate or etanercept alone in retarding the rheumatoid arthritis disease process and improving function and achieving remission. And if you look at this graph here, this is from one study where the monotherapy with methotrexate and etanercept have been used, and they cause 13% and 16% improvement and remission in patients with rheumatoid arthritis, respectively. But when these two drugs are used in combination, they have a synergistic, better outcome and can induce remission in around 40% of patients. Etanercept has the same side effect profile as the other biologic DMARDs. Golimumab is another antibody that neutralizes the biologic activity of tumor necrosis alpha by directly binding to it and blocking its interaction with the surface receptor, similar to the previous drugs. And this as well can be used either as a single drug or in combination with methotrexate. It has a unique adverse effect, is that it can be associated with the reactivation of hepatitis B in patients who have dormant or latent hepatitis B infection. Infliximab is a chimeric monoclonal antibody composed of both human and mouse regions. So this is not a human or humanized monoclonal antibody. It has both human and mouse components. The antibody binds specifically to tumor necrosis factor alpha and inhibits its binding to its receptor, the same mechanism of action as the previous drugs. And it has been approved for the use in combination with methotrexate in patients with rheumatoid arthritis who have had inadequate response to methotrexate monotherapy. So you would start with methotrexate, and then you would, if it doesn't work or doesn't give you the expected effects, then infliximab can be combined with methotrexate. The agent, or this agent, is not indicated for the use as monotherapy, and I will leave that for you to look it up. The drug is given intravenously, and it's indicated for a variety of other autoimmune diseases, including psoriasis and psoriatic arthritis, inflammatory bowel disease, and ankylosing spondylitis. Again, this drug has the same adverse effect profile and cautions, and which are similar to those of the other TNF-alpha inhibitors. Another drug in this category is abatacept, which is a soluble recombinant fusion protein. So this is not exactly a monoclonal antibody. Remember from the pathogenesis of rheumatoid arthritis that T lymphocytes need two interactions to become activated. They need to interact or have the antigen presenting cell interaction. That is usually an interaction between the T cells and the dendritic cells or macrophages presenting the antigens to them. That's the first step in the activation of T cells. And then another, or step 2 activation, which is mediated by the CD80, CD86 receptor interaction. So from your immunology, and as we've discussed this in the hematopoietic system, these two steps are very important in the priming of T cells. So abatacept competes with CD28 binding on the CD80, CD86 protein or receptor interaction and prevent the step 2 T cell activation. And this drug is used for the treatment of moderate to severe rheumatoid arthritis or those who have poor response to the conventional DMARDs or TNF-alpha inhibitors. So this is the first example of a biologic DMARD that is not a TNF-alpha inhibitor. Rituximab, which you have also been introduced to as a powerful immunosuppressant, interferes with the function of B lymphocytes primarily. So B lymphocytes, which are also derived from the bone marrow, are necessary for the efficient immune response. And in rheumatoid arthritis, B cells can actually affect the inflammatory process. They are part of the pathogenesis of rheumatoid arthritis. And they can activate T lymphocytes. They can produce autoantibodies directed against self-antigens of the joints. They can also produce pro-inflammatory cytokines such as TNF-alpha and interleukin-1. So drugs that target B lymphocytes have also been shown to be effective for the treatment of rheumatoid arthritis. Rituximab is one of those monoclonal antibodies that target CD20, which is expressed in B lymphocytes, and that results in inducing apoptosis or cell death in B lymphocytes, resulting in their depletion. And that definitely reduces the inflammatory process associated with rheumatoid arthritis. And that's why rituximab has been indicated to be used in combination with methotrexate for moderate to severe rheumatoid arthritis.